let's welcome next speaker, Dr. Pascal, please.
Okay. Thank you, Luis. Thank you, everyone, for it's a pleasure to be presenting this morning. Can you see the slides and everything?
Yes.
Yes.
Perfect.
Okay. So I'm going to be talking about web complication management. Those are my disclosures. So it's like everything in life, it's evolution. Like in aneurysm treatment, a lot of new techniques coming out, and it's up to us to really do the patient selection. It's up to us to decide to match each aneurysm with the specific tool. And as I said, it's not one size fits all. It's very important to really be able to do a tailored procedure and be able to use all the tools against the disease. There's a disruptive innovation in medicine and disruptive innovation in neurovascular disease. We've seen it a lot in the last 10 years. We've seen it first with the concept of flow diversion, and then we've seen it later on with intrasaccular. And this is when a product emerges into an existing market, typically from outside established market leaders, and then relentlessly displaces established competitors. So this is the definition of disruptive innovation. As you know, the web device is an intrasaccular device. This is the old version, double layer, but practically you're deploying this device in the aneurysm and hoping that it's going to create thrombosis. And we were part of the WEBIT trial, and we've all seen those pre and post imaging of aneurysms treated with web, MCA aneurysm, ACOM aneurysm, pre and post aneurysms like that, before and after. Again, but we've learned a lot since the trial, and I think we definitely know that it's not a panacea, and we know that there are some indications and there are some downfalls. We learned that sizing is key. It's very important to oversize the device to be able to prevent any flow going in the aneurysm and to prevent the shortening of the device for that. Now, what type of trouble we can run into during the procedure? I'm going to talk during the web procedure. Sometimes we need the use of adjunctive devices for bailout or rescue. Let's start with the balloon, for example. The balloon isn't very helpful if a web is already deployed and it's protruding on the parent vessel, because you're going to inflate the balloon, it's going to deform the web, then the web's going to go back to its shape. The balloon is more interesting in case sometimes you want to do a balloon-assisted web placement to change the direction and the deployment of your device. You can use the balloon. Stent for protrusion and occlusion. Sometimes if you have protrusion to the parent vessel, and I'll show you some cases, placing a stent in the vessel may keep your vessel open. Jaying a wire 14 or a 16 or 18 wire and going with a microcatheter to push and deform a device at the site of the detachment also can deform the device and decrease the protrusion. And then at the end, retrieve the web. There were some papers showing how you can retrieve a web with a stent retriever. This is a case of an ACOM aneurysm, as you see here, that was treated with web, and the web was deployed, and then here it is. You see the delay filling of the A2. In this case, what we did is the web was already deployed. We deployed a stent from the A2 to the A1, and then re-established the flow. This is one of the few cases where you have a complete occlusion of the aneurysm. As soon as you place the web, you have a complete thrombosis. Those are cases to worry about also with the hyperthrombotic state. So this is, you see the web device, you see the status of contrast, and you see the stent here in this case. This is a case courtesy of Dr. David Hassan from University of Iowa, an ICA bifurcation aneurysm that he decided to treat with coiling and web because it was too big for a web device. So he coiled it Then this is the web device that's being advanced to plug the neck, to cork the neck. And as you see here on the lateral view, that's the device being pushed. But what happened is the device herniated in the M1 in the parent vessel. In this case, the device was already deployed. So he went and tried to do a balloon angioplasty, but it wasn't enough. Then he deployed a stent and then ballooned inside the stent. You see the stent here is getting deployed. And this is the balloon angioplasty to crush the web device. And he was able to keep the MCA patent and there's still some neck at the aneurysm, but he was able to keep the MCA patent. So before detachment of a web, it's very important to make sure that you are in a neutral position because if you are too much forward, it can jump and rupture the aneurysm. If you're pulling on it, it can go in the parent vessel and can be dislodged. Once it's detached, be careful that there is still some, if it's touching still, if you pull back, even if it's detached, it can still move the web device. So you can advance your microcatheter on top of it and resheath the pusher. And if it's not detaching, sometimes you can get a 9-volt battery and put it on it and it will detach. This is a case where place the web device in this MCA aneurysm. As you see here, the web is getting pushed and the web here is in the aneurysm. And it's very important to watch the vector force. So as you see here, this aneurysm is coming down. Your vector force is going that way. And after the web is detached, this is what happened. Take a look here on the direction. Take a look now. It twisted completely after it was detached. And usually the flow diversion is mainly at the both poles of the web, not at the side. So now we have the side exposed to the neck, and this is the Dyna CT. But then on follow-up, the aneurysm looked okay. So very important to look. In this case, there was too much forward tension on the catheter, especially that the vector force is going the different direction. Managing of intra-op procedure rupture, very important to stay calm and think. And those ruptures can be dramatic in comparison to what we're used to. So this is a totally different device. And we're used to having a rupture with a coil, having a rupture with a wire, with a microcatheter. In those cases, if the web is jumping in the aneurysm, then getting and opening up in the rupture at the hole you created at the dome, this can cause a really big rupture and big flow, and this can be a problem. So very important to start with basics, to reverse the patient and try your best to pull back and deploy the device in the aneurysm. And this we learned it the hard way. Sometimes, you tend to pull or resheath the device quickly, but if you have an intra-op rupture, it's very important to stay calm. If you have a balloon, great, you inflate your balloon and try to manipulate. And then very important to pull back your web and try to keep it regardless in the aneurysm. This is a case courtesy of Adam Arthur, a basilar tip aneurysm. This was during the Webbit trial. That's the aneurysm that was going to be treated. This is the web device, as you see here, getting deployed. And this is the run. And you see there's extrav from the dome of the aneurysm. Very important to know that this device, if it's not open, it's very hard. So the tip of the web is like a harpoon and it's hard. As soon as it opens up, at that time, it becomes soft. But before that, this is really stiff. And this is stiffer than what we've ever put in an aneurysm before, like stiffer than a coil or anything like that before it opens up. So what happened here is he went up with a balloon, tamponaded it, and then brought back the device in the aneurysm. This is when the balloon was inflated. And this is after deflation. He would pull back the web device in the aneurysm, and then the extrav stopped. And this is the end And then on long-term follow-up, 1 year follow-up, he had an adequate result and occlusion, and the patient did well. And this is a 5-year post-treatment. As you see, complete occlusion, 5 year post-treatment. As I said earlier, before the web is open, it's stiff. This is an unfortunate case of mine of an ACOM aneurysm that actually, as you see here, the web ruptured the aneurysm and then opened up. And this is what I'm talking about, of the web opening and dilating the whole of the aneurysm. This case ended up right away putting 2 ventricles, coiling the aneurysm. But as you can imagine, the patient didn't do well. What about thrombotic event? It's very important. You know, the web device is a device where you can, put it there and it will mimic the final result, and you don't have to detach. Uh, like it's not like that in a flow diverter, because in a flow diverter you can resheath, but you can never deploy it completely, see how it looks like. Then if you don't like it, you're gonna resheath it. So in the web, you place the web, you look, and then sometimes it's you can see that it's there's some stenosis, or there is any delayed flow in one of the vessels, and at that time you can resheath this and change the plan. This is a recurring aneurysm after coiling, where we decided to try to use the web device as corking the neck. But here it is. As soon as we placed it, we see that there was an occlusion of the A2. So in this case, it wasn't deployed. We resheathed it, and then the patient went to the OR, and we clipped the aneurysm. Difficult anatomy, very important to not to worry about the access. That's why when I proctor web at the beginning, the first cases I recommend always to have a lot of support, have triaxial system, and because you don't want to worry about that when you're using a device for the first time. Sometimes challenging in centering the microcatheter, and this is important. As you know, those are big catheters. We still don't have small catheters for small webs in the US, but they exist in Europe. And sometimes you need to unsheath completely the device before it opens completely, and then you decide what to do. There is always a forward movement of the device when you're coming up. So this is a case of a MCA aneurysm, very tortuous. Uh, and you see here, because of you cannot really center the microcatheter in the aneurysm is here, and this is going on the wall of the aneurysm. So very important here not to be able to unsheath, not to push forward at all. This is where the web is very stiff, and that's a dangerous move here. So it's going along the aneurysm, so you're gonna keep on unsheathing. Uh, and as you see here, all the way, and it still didn't open up. And we're unsheathing more all the way until it opens up at the end. So as you see here, still not opening up. And then at the end, release the tension, and here it is. It opened up, and here it is. We're gonna detach it, and then that's the detachment. As you see, it's gonna flip a little bit. Once you detach, you take a look at the detachment zone here, and here it is. It's detached, and that's the final run showing stasis of contrast. This is another case courtesy of Dr. David Hassan. That's an aneurysm that he decided to treat with 2 webs because it was too big, and then it was protruding, so went in with a jade microwire and microcatheter and pushed it all the way to decrease impingement. And as you see here, it remained. This is a case of Adam also, ACOM aneurysm that was treated. As you see here, that's the web device in the aneurysm. You see some stasis, and that's the lateral view. Then, for some reason, it got pulled back, as you see here, after detachment, and went into the parent vessel in the ACOM complex. As you see here, it got pulled back. So in this case, he went up nicely with a jade wire and microcatheter. That's the web device here, and he pushed it in the aneurysm. So you're gonna see here, microcatheter, microwire, and the web is all the way down, pushed in the aneurysm. That's the final result. And this is a 6 months follow-up showing a complete occlusion. Sizing is important. This is a web that got dislodged. This is a lady that presented with a subarachnoid hemorrhage, had this pica aneurysm, two separate pica aneurysms. In this case, I decided to treat them as two separate aneurysms and place a web device. This was the first aneurysm. I placed the web device in it, and this was the stasis. Let me see here. That's the web in one lobe. That's the web in the other lobe. I'm detaching it. That's the web in both aneurysms with stasis. You see both webs next to each other. And then after that, what happened is we were doing the run, and very important to look here and see. So as you see here, you see the shadow of that web here. And then you see something here. So when we first stepped on the pedal to do the run, the web was still in place. As soon as we injected with the pressure of injection, and there was some protrusion of the web in the parent vessel, it was a judgment mistake from my part, tolerating this protrusion or using web in this particular case. At that time, the web flew all the way here. Happened after we stepped to do the, so we did a vert deconstruction procedure, kept the web in the vert. Thankfully, the patient had a patent vert on the other side. The patient actually did well, other than just a partial 6 nerve palsy. Patient didn't have any strokes, and then did well. Rescue of migrated web. This is a paper showing that you could go distally, deploy a stent retriever, and then pinch the web and take it out. I've never had to do this, but this is something to keep in mind. Web in ruptured aneurysm. This was our paper in neurosurgery about web in ruptured aneurysms. I think it can be useful in cases where the patients are not a candidate for open surgery for a clip. I'd rather use an intrasaccular device instead of using, stent-assisted coiling and stents in the parent vessel where the patient needs to be on dual antiplatelet therapy in the setup of a subarachnoid hemorrhage. Couple of cool pictures. This is a case where the patient had multiple aneurysms presented with a rupture. They treated one with web that took care of it, and the other one needed to be clipped. So I took the patient for a clipping and took a sneak peek on the web device in the treated PCOM aneurysm, and that's how it looks like. Recently, I clipped a recurrence of a web. The web device can be crushable easily with a clip. This was a recurrence at the neck, actually. I went in, I was able to place my clip and closed it, and I was able to crush the web and close it, as opposed to when you have coils, you cannot do that. So I think devil is in the details. As I said earlier, it's important to pay attention to all the details, and it's not one size fits all. It's trying to use all the tools for the disease. We shouldn't be advertising for tools. We should advertise for... All right, thank you very much.
Thank you very much, Pascal. Fantastic presentation. Many questions. Dr. Professor Juha, what do you think about the intrasaccular device, the web device to treat the aneurysm? What is you have a comment?
I have no comments, because what I feel here in China, 4 people are coming to open microsurgery. Rich people are having endovascular surgery. In Nepal, the people didn't have money to buy a clip for the ruptured aneurysm. So I think there's something wrong in the organization of the world. We are speaking like first class society here.
Yeah.
Yeah, that's a very important point.
We are making all the time better and better devices. It is difficult to follow up what they are. So, for example, in the giant aneurysms, the bypass surgery would be by far cheaper solution.
Yes. And
Yeah,
balloon,
Luis.
balloon,
In Chinese market,
I grew,
the web was still waiting for the approval from the government. So we already finished the clinical trial and waiting for the approval from the government.
You
So
found-
still not,
I just
we don't have the web in the market yet.
I just thought to make a comment
And
to
the
you
price
that
is of the web. How much is the price of the web?
$15,000 in the US. But we got to remember, this is not a problem only to neurosurgery, right? We have chemotherapies at $1 million per patient. So that's a problem of modern medicine that I think as a world, we need to solve this equation. Again, some immunotherapies are $200,000, $300,000, not $10,000, $200,000 per dose. So again, that's a problem that is everywhere in modern medicine.
Yes. But it's not the same in USA, at Nepal or Spain or Brazil. No. Yes.
No, it's not. It's not the same inside the same country.
Yeah.
Again, if you are in Brazil or if you're in Spain and you have good insurance, you have money. So
how many cases you treated for a year with balloon occlusion, tight occlusion and balloon occlusion of the parent vessel? Never.
we don't have balloons available in the US anymore. They took out of the market.
I treated more than 200 patients with this technique. I have never the complication of the rupture. Only one case rupture, the aneurysm, when I inflate the balloon. But why stop the balloon technique? It's at the same of the onyx of aneurysm. Why stop? You don't have.
Luis, are you talking about, I didn't get it. Are you talking about parent vessel deconstructive procedure, shutting down the parent vessel?
No.
Detachable balloon. Detachable balloon.
Parent vessel occluded. Detachable balloon.
Yeah, but you're talking about parent vessel occlusion.
Yes.
Temporary balloon occlusion.
No. Temporary occlusion, test occlusion, and then.
Yeah, okay.
Yes, I have more. I started this in 85, 84. Is why I stop, because don't have this product. Hanel, Ricardo, I agree, but you're going to Brazil. I am sure the Brazilian doctor or patient have the solution with balloon occlusion.
Yeah,
No.
That's where I have more experiences from treating patients in Brazil with colleagues there. But Luis, if you look objectively on the literature, what is there is not your experience. If you look at a complication rate for deconstructive techniques versus reconstruction of the parent vessel, the complication rate is higher with shutting down the vessel than saving the vessel.
No, this is not true. No. This is not true. I have experience more than 200 cases. It's not true. If you want, I take you the information. But
no, I respect your opinion. I'm just telling what the literature tells us.
And you have the experience of Servinenko. It's not true every paper of Servinenko, but it's true also. No. This is another point of discussion.